Good evening, my name is Dr. David Doman, and welcome to another edition of Housecall. What is new with vertigo? What is new with dizziness? Find out more right now. My guest this evening is Dr. Ezra Cohen, a noted neurologist with the Neurology Center, practicing right here in Montgomery County. Ezra, welcome to Housecall.
Thanks for having me, Dave.
My pleasure. Now, briefly tell our viewers about your professional background.
Well, I grew up here in Montgomery County, Dave. I went to Richard Montgomery High School, and then I left to go to college at University of Michigan, and I did my medical school and residency at Mount Sinai School of Medicine in New York City, where one of the people I worked with was the great Dr. Bernie Cohen, no relation, a world expert on dizziness and vertigo, who was the holder of the longest running U.S. government science grant that ran for 50 years, partly funded by NASA to study dizziness in space. And he influenced a lot of the people who trained there. I did a fellowship at NYU in other parts of neurology, and then moved back to the area, and I've been in practice with the Neurology Center for 18 years. I work out of an office in Rockville 3 days a week and downtown in K Street 2 days a week.
Very nice. So, briefly tell our viewers about the difference between dizziness and vertigo.
Thanks for asking. It's a very important question for us because people will often use the word vertigo when describing how they feel, whether or not it actually reflects what we consider to be vertigo. Vertigo is a sense of abnormal movement, often spinning, but not always spinning. Sometimes it can be a swaying sensation or other forms of abnormal sense of movement. Dizziness refers to many different things. Many patients will say that they feel dizzy. What they're actually referring to is a lightheadedness, a feeling like they've stood up too quickly and that they may become faint or pass out. And that is usually from blood flow issues, sometimes cardiac problems, but it is not usually a sense of abnormal movement. Some people will talk about feeling unsteady on their feet when they actually don't feel any kind of dizziness in their head, but they will use the word dizziness to describe it. And that's usually from lack of sensation from the feet from a problem like peripheral neuropathy, and they don't feel dizzy in the head. And sometimes people are just talking about a sense of brain fog, like their head doesn't feel clear, without a sense of abnormal movement either. And that can be from a lot of different causes, but vertigo is specifically a feeling of abnormal movement, usually spinning.
Interesting. So, given that there are these differences, what are the major categories of vertigo?
So, we tend to divide vertigo into two categories. There's central vertigo, which is related to problems of the brain, and peripheral vertigo, which are related to problems of the inner ear apparatus and the nerve that supplies it.
And show us, if you can, some of the anatomic aspects of the inner ear and how these structures could be related to so-called peripheral vertigo.
So for the inner ear, you can see in the diagram here, the outer ear is on the left side, the part that we're all familiar with, and then the ear canal leading to the tympanic membrane, which is the eardrum. And the eardrum is the start of the middle ear, and you can see the bones in the middle ear. And this is responsible for transmitting sound to the inner ear. And you can see the inner ear on the far right side in blue. There's two main sections to the inner ear. There's the cochlea, which is on the right side. It's the spiral shape, which is where sound is collected and transmitted to the vestibular cochlear nerve, which you can see in yellow, supplying that structure. That's where hearing happens. Above that and to the left, you can see the vestibular apparatus, which has a couple of different parts, which I can show you on the next slide in close-up. So the diagram in the middle is the vestibular system, and there's the cochleas there as well. And you can see that there's several small organs inside the vestibular system. There's a large open section that contains the macula and the saccule, and then there's 3 semicircular canals. And each of these has a different function, which we're going to get into in a little bit when we talk about the different problems.
What are the different types of peripheral vertigo?
So there's a couple of causes that are more common. The most common of which is benign paroxysmal positional vertigo, which we're just going to refer to as BPPV. Mm-hmm. And this is one that we'll talk a little bit more in detail on when I show you the diagram again, but it is usually due to a problem with the crystals in the inner ear, and it's a problem a lot of people have heard of with those crystals. The second problem is what's called vestibular neuronitis, which is a problem of the nerve itself, and is probably a little bit less common, but still affects a lot of people. And then there's two less common causes. One is Meniere's disease, and then another is what's called superior canal dehiscence syndrome.
Define Meniere's syndrome.
Well, Meniere's disease is one of the less common causes, and Meniere's is a combination of a few different symptoms. There's a problem with the nerve itself that causes the vertigo, but there's also hearing loss and ringing in the ears, and often a sense of fullness. And it can be due to several different kinds of factors. Autoimmune diseases can sometimes cause it, sometimes problems with the fluid circulation. And it's really best addressed by an ENT rather than a neurologist because there's other factors at play. But for our purposes, it looks a lot like vestibular neuronitis on testing and how it affects people. So whenever I find that problem, I like to refer to an ENT to help them try to figure out if the patient has Meniere's and what to do about it.
And what are some of the other pathologies that can cause vestibular neuronitis?
Well, vestibular neuronitis is usually viral. It's usually a problem when a virus attacks the nerve to the inner ear. But you can get it also from head trauma, or tumors can cause a similar kind of pattern to what we see with the viral attacks. But most of these patients have viral illnesses.
Now, when you say tumor, do you mean like a central nervous system tumor, like a glioblastoma, or is it more something like an acoustic neuroma? More like an acoustic neuroma, because we're talking about an effect on the nerve itself rather than an effect on the brain. And please explain to our viewers, since we're getting pretty technical now, what exactly is an acoustic neuroma? Acoustic neuroma is a benign tumor, but anything that grows inside the head is by definition a problem, whether it's benign or not. They're usually benign, but not always. And they are growing off of the nerve or the lining of the nerve itself. And we see them, they're very similar to meningiomas, which is another problem that people have heard of a lot, where they can compress structures on the outside of the brain because they're growing off of the outside of the brain or the nerve. And the acoustic neuroma specifically grows in the canal for the nerve and can affect it, causing hearing loss or vertigo potentially. And what's the treatment for that? That's a surgical treatment. Sometimes radiation is used, but usually it's treated surgically, and we refer to our neurosurgical colleagues for that. Okay. So in terms of key features, what are some of the common issues you see, and how do they present? Well, let me tell you about benign paroxysmal positional vertigo first, because that's really the most common cause that many people have either suffered from or are familiar with. I'm going to have them pull up the diagram again, and I can show you here that in the close-up diagram that there's two organs on the middle of the vestibular system. There's the macula and the saccule. And these are not directly involved in BPPV, but what they are is there are acceleration monitors. This is how we can tell when we're moving forward, backwards, up, or down. And the way it works is that there's very sensitive hair cells that are attached to the nerve cells. And when you move forward quickly, the membrane sitting on top of those cells moves backwards due to just the opposite movement. And it can trigger the hair cells and tell you that's how you can feel when a car is accelerating or decelerating. But for that system to work, you need to weigh the membrane down a bit. And that's why we have what's called the otoconia, or the otoliths. These are small crystals that sit at the top of the membrane, and you can see them in the close-up of the drawing. So you have those on both the macula and the saccule. And over time, sometimes with head trauma, sometimes just with aging, and sometimes for no reason at all, they can become dislodged. And when they do, they often float around the chamber, and you can find them sometimes falling to the top of the chamber, which is where the semicircular canals are. You can see them, the three circular canals sitting at the top of that diagram.
And the semicircular canals are the way we sense rotational movement. So when you turn your head to the side quickly, you can tell that you are doing it because the semicircular canals are triggered. The fluid hits a hair cell trigger, like what you have on the other organs, and you can sense that sideways movement of your head, rotational movement of your head. And it's in all three directions. You can see the way they're laid out like that. So the problem with BPPV is that these loose crystals fall into the top of the chamber when you lay backwards, because gravity will pull them down there, and they can become lodged next to the hair cell trigger. And what will happen is when a person lies backwards and turns to the side, and sometimes just lies backwards, or sometimes does nothing at all, they can suddenly feel like they're spinning because the cell is being triggered right there. So that's how BPPV works.
So then, since we're focusing on BPPV so much, how do you treat dislodged crystals?
So gravity is what gets them there, and gravity is how we get rid of them. Is that we will, the first thing we have to do is we have to diagnose the condition. And to do that, we do what's called the Dix-Hallpike maneuver. And the Dix-Hallpike maneuver is we have the patient sitting on a table, and we have them lie backwards very quickly with their head coming off the back of the table, falling down a little bit, but with their head turned to the side. And we do it one time to each side. If the problem is in the left in the left canal, in the posterior canal, which is usually where this happens, it could be on either side, but usually it's the posterior canal, and we have their head turned to the left side, they will immediately trigger vertigo, and they will have what we call nystagmus. Nystagmus is the main thing that we're looking for here, and we can talk about that in a minute. And if it's on the right side, then it'll show up when we have them lean back to the right.
So why don't we go on to discuss nystagmus, and then I want to discuss either now or when we follow up in the second half of the program how to treat this problem.
Sure.
So nystagmus.
So nystagmus is an abnormal movement of the eyes, and we all know that the eyes are the window to the soul. But it's also true that the eyes are the window to the ears, is that we can learn a ton about what's going on with the inner ear by looking at the eyes. And the reason is that we have very tight circuits between the two so that we can track things when we're turning our heads. If I turn my head this way, but my eyes stay focused on you, I turn my head that way, my eyes stay focused on you. And we sort of take that for granted, like that's a natural thing to have happen. But when it does happen, our eyes are actually being forced to move to one side while our head turns to the other side. And it's only because we have such a tight circuit between our ears and our eyes that we're able to do that seamlessly. And because there's that tight connection, as soon as something goes wrong with the inner ear, you can see it in the eyes. And what nystagmus is a jerking movement of the eyes to one direction, followed by a slow movement of the eyes back to the midline, and then another jerk. And what we perceive is the jerking, the quick jerking movements. And they can be to the left, to the right, up or down. They can be rotational. They can really go in any direction. And they are the best exam feature we have for diagnosing these conditions. In benign paroxysmal positional vertigo, BPPV, the movements are rotational towards the side, the fast movement towards the side of the involved ear. And we can see that when we do the Dix-Hallpike maneuver, is that the eyes make these rotational movements, and it's unmistakable when you see it. And the person will also feel very dizzy and vertigo at the time that it's happening. So that's how we diagnose it, and then we can also treat it with maneuvers.
Great. I do want to speak about treatment specifically in a moment, but we're going to pause briefly for a public service announcement. More with my guest, Dr. Ezra Cohen, and we will be discussing assessment and treatment of dizziness and vertigo. We'll be right back.
I'm 5'11", barely 5'4".
I weigh about 170 pounds.
Brown eyes.
Blue eyes.
Brown hair.
Gray hair.
I'm a baseball fanatic.
I'm a wife.
A mom.
A sister.
And a grandfather.
I'm a bodybuilder.
I'm a research analyst.
Small business owner.
Teacher.
Dance fitness instructor.
Film and television actor.
I'm an office clerk.
I'm a copywriter.
I'm a veteran.
I have a prosthetic leg.
I have multiple sclerosis.
I have lupus.
Cerebral palsy.
Post-traumatic stress disorder.
I'm blind.
And I'm working in a job I love.
I love.
Because I was given a chance.
Because I was given a chance.
To contribute my skills and talents.
To show my disability is only one part of who I am.
Who I am.
Who I am.
At work, it's what people can do that matters.
For more information, visit whatcanyoudocampaign.org.
We're back. My guest this evening is Dr. Ezra Cohen of the Neurology Center, and we're discussing assessment and treatment of vertigo and dizziness. Ezra, when we paused for the break, we were discussing BPPV, and we were about to go on to discuss therapeutic treatment options. Explain to our viewers what options are available.
So the best way to treat BPPV is soon when it's happening, because the worse a person feels, the easier it is for us to prove the diagnosis and to do a maneuver that can help them quickly. And there's very few things I can do in my own office with two hands that can fix a problem right then and there. And this is really probably my favorite one, because we can really make people feel better much quickly. And people are feeling very dizzy when they lie back. We do the test on them, the Dix-Hallpike test that we talked about before. And as we do that, we can then go straight from that to what's called an éplé maneuver. And the éplé maneuver is a series of maneuvers we have the patient do where they turn on their side. First they turn, if say the vertigo is on the left side, they turn their head back into the left. We have them turn their head to the right side and then turn their body to the right side with their head facing the ground, and then to sit up. And what this does is it pulls the otoliths, the otoconia, that are stuck in the semicircular canal out of the canal and frees them and has them float back into the main chamber, getting them off of the hair cell trigger and preventing the person from feeling the vertigo when they lie backwards. Sometimes we'll do it a couple of times and it's fairly effective. The problem is it can never be fully effective, because the otoconia can never be reattached to the membrane that they came from. So they will always be free floating in that chamber, which means they always have the potential to go back into the semicircular canal and cause vertigo again. So we end up seeing patients sometimes a year later, sometimes less, sometimes a lot more, where they have a recurrence and we treat them again. So the éplé maneuver is really the mainstay of treating this problem, but we also refer patients for vestibular rehabilitation, which is very effective for them. And that's where a physical therapist will sometimes do this type of maneuver or other types of maneuvers to help with the problem. And sometimes when the problem can't be fixed, they can teach them different ways to get more used to how they feel and not have it be so unpleasant.
I'm sure our viewers are wondering, is there any medicine you can prescribe for this problem?
Well, people often use meclizine, which is a suppressant of the abnormal sensation, but I don't find it to be too helpful, especially for this problem specifically.
That's Antivert?
Yes.
Okay.
I don't find it to be very useful for this. It's the kind of thing almost every emergency room ends up giving it, but it doesn't work very well, especially with this vertigo, which is so positional. As soon as the people go into that position, they really feel awful. So it's the maneuvers that are by far the best way to treat this.
Is there any operative options?
Not that I know of, and it seems, I think that anything that you do in that area has the potential to worsen the problem, not make it better.
Sure.
So it's not something I've ever seen someone referred for, and it doesn't seem like it would be a good idea to me.
Sure. So what are some of the other less frequent causes of peripheral vertigo?
So we talked before about vestibular neuronitis, and what that looks like is the person is having a viral attack on their inner ear, and it tends to be very aggressive, very severe vertigo, often when they first wake up in the morning, almost always accompanied by nausea and usually vomiting, and the person barely can move at all because they feel so unwell. But it's a little bit different than BPPV, is that it's not specifically when lying backwards or turning on the side. It's really any position or any movement makes them feel quite bad, and those patients are best served by treating with prednisone, with steroids at first to take down the inflammation and hopefully lessen the amount of damage that's done. But nothing can really repair the damage once it happens, and we can see that on some of the testing we do in the office. But it is they often will have recurrences later on in life. What happens is that they have this very severe episode at the beginning. Their body, their brain learns to adjust to the amount of vertigo that they have, and it goes away, but will recur when they lose that compensation gradually, over time when things happen, like an illness or especially an ear infection or something like that can cause the symptoms to recur, usually similar to the first time, but not as severe. And when that happens, we can suppress the vestibular response fairly well with low dose of Valium, which is what I tend to prescribe, and I like them to have it on hand in case they need it, and those recurrences don't tend to last long and they're not as bad as the initial time.
So we do want to go on to another important topic, which is central vertigo. Explain to our viewers what is the difference with peripheral vertigo.
So central vertigo, as we said at the top, is a problem that comes from the brain. And the symptoms are similar. The patients will feel a sense of abnormal movement and or spinning, but it's not usually as intensive as spinning, and it is not usually as clearly a spinning sensation. Sometimes it's a little bit more vague. And we will see nystagmus for these patients too, potentially, but it is often a different kind of nystagmus. Maybe it goes upwards instead of being rotational or going off to the side. It's less predictable. And we can see it from several different kinds of brain problems. Really anything that can negatively affect the brainstem or the cerebellum in the back and bottom of the brain can cause this. So we can see it from a stroke, we can see it from multiple sclerosis, we can see it from a tumor affecting the brain, and most commonly we see it from migraine, which we can talk about a little bit separately. But the first task is we really want to make sure that they don't have one of these more severe problems. And there's ways to, there's certain hints that could be the case.
And how does one do diagnostic testing to make the distinction between peripheral and central vertigo?
So the main test that we use in our office, besides bedside testing, is what's called a video nystagmogram, a VNG. And the way that works is we put a pair of goggles on the patient, and the goggles have cameras pointed at their eyes. And they enlarge their eyes, and we can record what the eyes do. As we said before, the eyes are key to understanding what's going on. We then have them do a series of tasks where they look to the side and they move their head in different directions. And those tests are very good at picking up central causes of vertigo. And then we have them do a Dix-Hallpike maneuver to pick up BPPV. And in the end, we put hot and cold air in their ears, and that's the unpleasant part of the test. Yeah. And that can induce vertigo. It should induce vertigo. And that's how we can tell if the inner ear is working well. If there's been vestibular neuronitis, it should show up on that part of the test. So it's a good test for evaluating any type of vertigo and can tell the difference between central or peripheral causes. Now, if we think it's a central cause, we always do an MRI of the brain, because those bad problems we talked about before, stroke, MS, tumor, they may have an unclear pattern of vertigo, but they always show up on MRI. Mm-hmm. So if we have any question at all that it could be a central problem, we like to do an MRI of the brain, and that can show us if the problem is there.
How interesting. And then you've mentioned the different causes of CNS vertigo. What are the treatment options?
Well, it depends on the cause. And first we have to recognize stroke. It's always essential to recognize stroke immediately, because the important treatment for stroke can only be done if the patient gets to the hospital quickly after the problem starts. So like any kind of stroke, it begins abruptly. It may be there on waking in the morning, but for most people they can notice an onset where suddenly they have the sensation that they didn't have before. And one of the keys in stroke is that there's usually, but not always, other symptoms that go along with it. The patient may have difficulty with speech or difficulty with swallowing. They may have double vision or loss of vision. They may have weakness. They may have numbness, and sometimes headache along with it. So it is usually this other symptoms that give us the clue that that's the problem. And obviously anyone who thinks that they are having a stroke needs to get themselves to an emergency room right away. And then medications can be used to break up the clot that is causing the stroke. So we always encourage our patients to take action as quickly as possible. That's the main treatment for that type of vertigo. But if the person has had a stroke and is left with vertigo, then we really don't have as many good options. It doesn't tend to be one of the more lasting symptoms from stroke, though it can happen. But things like Valium, medications like that, can suppress the abnormal sensation there. And with multiple sclerosis, our treatment is the same as it is for any of those patients, where we're going to treat the immune problem and hopefully suppress the symptoms if we have to.
Now, you mentioned the importance of somebody having onset of possible stroke symptoms quickly getting to the ER for evaluation. Please define what you mean by quickly, because there is a window within which so-called clot-busting drugs maximally work.
Right. Thanks for asking about the specifics. It used to be considered 3 hours was the amount of time that a person needed to get there, but that window has enlarged as we have new therapies. So it is if a person is there within the first 3 to 4.5 hours, They can be given regular clot-busting drugs in the emergency room, but there are now procedures that can be done where a catheterization can be done, and the clot itself can be removed, and that can be done within the first 24 hours, I believe. But the window keeps enlarging as the therapies get better. What's important to remember is not to wait to the end of the window. Mm-hmm. The earlier a person gets to the emergency room and gets treated, the better their outcome, regardless of what therapy is used. So even if, as soon as the person knows that it's happening, it's important to get there because earlier is better regardless of how we treat it.
So if somebody's at home and it's the evening and they suddenly have funny sensations, they should not say to themselves, oh, let me sleep on it and I'll see how I feel in the morning.
Right. They also should not wait to call a relative or their doctor. They should go immediately because we don't want to have to tell the person over the phone once we get the message that you have to be there immediately. It's important for people to understand that they have to get themselves up and get someone to get them there, even potentially before an ambulance, get there as soon as they can.
Absolutely. Now you mentioned in passing migraine.
Yes.
And that it can trigger vertigo. We have 2 minutes left, so briefly tell our viewers about that interplay between migraine, headache, and how it can present with vertigo.
So we don't really know why migraine causes vertigo. We know what's happening in a migraine. We know that there is abnormalities of blood flow within the brain, and there's also electrical abnormalities. And the electrical theory is the one that's probably most subscribed to at this point. And for some people, migraine headaches, we all know they cause headaches, but you can have a migraine without any headache at all. And one of the most common other kinds of migraine to have is what's called a vestibular migraine, or migraine-related vertigo, where the brainstem is more affected for reasons we don't know in certain people, and they can develop a sense of dizziness and pure and true vertigo. And that vertigo is often not exactly the spinning sensation we see in BPPV. Sometimes it's more of a swaying, and there's often migraine-related symptoms that you might expect, headache, but sometimes not, and other things like nausea, which you can get from other kinds of vertigo, but also lights bothering the person or noises bothering them. Sometimes they have trouble looking at visual patterns or light coming through the trees, and that gives you a clue that it might be migraine-related. And we treat that the same way we treat all our migraine patients, with medications to make the migraines less likely to happen and medications to treat the migraines when they occur.
We have 30 seconds left. If our viewers have any questions, how can they reach you?
So I'm at the Neurology Center in our Rockville office and also downtown. Our website should be up on the screen, and we can appointments can be made that way, or people can call. And I love treating dizziness, but also really any of your neurologic problems. So feel free to reach out if you're looking for some help.
Thank you for an excellent interview.
Thank you, Dave.
My thanks to Dr. Ezra Cohen for a superb interview. My thanks to my team here at the station. And finally, my thanks to you, the viewer, for welcoming us into your home. Let us know how we are doing. You can reach me at the website listed below. As for our next show, we have as a guest Dr. Karen Dunleavy, Chief of Hematology and Oncology at Georgetown Medical Center. And we'll be discussing the latest developments in the treatment of leukemia, lymphoma, and multiple myeloma. It's going to be an important show. See you then next time for another edition of Housecall. Good evening.